Yes, hello again. And the title of this lecture is going to be Pharmacology 101. And we're going to talk about antibiotics in general and some of their properties and dosing features and so forth. I want to start by talking about a dose-related toxicity as opposed to idiosyncratic drug reactions, first of all, because as you know, I'm a stickler for the first rule of medicine, which is do no harm. So most of what we do in internal medicine, and pretty much all that we do in infectious disease to help the patient, is either decide not to give antibiotics and don't add any risk to the patient, or give antibiotics. So if we decide to give antibiotics, we better know everything there is to know about the antibiotic and how it interacts with the human body. So dose-related toxicities are such that you need to think of them in terms of poisoning. And pretty much every medication, if you surpass the intended or the pharmacologic dose in a particular patient, some sort of toxicity will develop. For instance, if you give too much chemotherapy for a particular cancer, you will notice that the bone marrow will take longer to recover, or you can have more serious side effects such as nausea and so forth if the dosage is too high. So how do we know how to properly dose a patient? And the antibiotics that we use primarily are excreted through the kidney, especially the beta-lactam antibiotics, vancomycin, aminoglycosides, sulfa medications, quinolones. And therefore, if the patient has renal insufficiency and we don't reduce the dosage of our antibiotics, the blood level and the systemic levels of these antibiotics will surpass the upper level of the pharmacologic dose and extend into toxicity or poisoning. When it comes to the beta-lactams, you've noticed that we always need to first look at the creatinine and the creatinine clearance, because the vast majority of beta-lactams, with the exception of rocephin and nafcillin, are excreted through the kidney. And if there is renal insufficiency and we don't reduce the dosage of the beta-lactam antibiotics, we run the risk of creating dose-related toxicity. So what is the main dose-related toxicity with beta-lactams, especially penicillin and even carbapenems like the marum that we use or the ertapenem that we use? Let's say a patient has a creatinine of 6 or 7 and their creatinine clearance is less than 10, and we give a full dose of penicillin or ampicillin because we're treating a streptococcal infection, let's say. What do you think will happen? Well, most of the time I ask this question, the residents or the students will answer, well, it is excreted through the kidney, so I'm going to say more kidney injury. But the answer happens to be wrong. The answer happens to be, if you give too much beta-lactam and you surpass the pharmacologic level, you get into toxic level, what will happen is CNS toxicity, twitching, or myoclonus, or seizures in the worst case scenario. So the main reason, and you may not have realized this, that we reduce the dosage of beta-lactams in renal insufficiency is to prevent seizures and neurotoxicity. And that really is the main and most important reason we go to all the trouble to adjust our dosage properly, not to mention we don't want to underdose as well, but typically that's not a problem. Usually we overdose. So other dose-related toxicities are important as well. Some antibiotics do have renal toxicity if you surpass their pharmacologic dose, namely aminoglycosides and vancomycin. but a dose-dependent toxicity of vancomycin and aminoglycosides other than renal failure include ototoxicity. So understand that that dose-related toxicities are predictable and can be absolutely preventable if we dose correctly, especially in regards to renal insufficiency. Idiosyncratic side effects from antibiotics are typically the side effects that we see most of the time. And these are side effects that are called idiosyncratic because sometimes they happen, sometimes they don't happen. And most of the time we really don't know why. And the common idiosyncratic reactions that we see are GI upset, diarrhea, nausea, vomiting. Cytopenias are important, neutropenia and thrombocytopenia in some people, and others it just simply does not happen. And allergic phenomena that we typically think of as a cause of a side effect, primarily IgE-mediated hypersensitivity reactions are the most scary. These include urticaria, bronchospasm, anaphylaxis, asthma, and so forth. Other drug allergies can occur idiosyncratically, including other sorts of rashes, such as maculopapular eruptions, fixed drug eruptions. Bactrim is notorious for that. And even Stevens-Johnson syndrome or erythema multiforme, major or minor. These are all, again, allergic or hypersensitivity reactions that will occur in some and not occur in others. So very importantly, we really need to consider that particular issue when choosing and prescribing an antibiotic. Antibiotics, like other medicines, have important drug-drug interactions, so we have to be aware of what other medications the patient is taking and if there is a potential drug-drug interaction. First one that comes to my mind is quinolones and amiodarone, insofar as the QT interval is concerned. As you're aware, probably, you cannot use quinolones if the QTc is greater than 475 because of risk of VTAC and torsade de pointe, which can actually lead to the patient's death. So it's so important to be careful with what you're prescribing. So not only do you need to know what the QTc interval is before you prescribe a quinolone, you need to know if they are on other QT prolonging medications, and you don't want to add any extra risk with the quinolone. For instance, if somebody is on amiodarone and the QTc is 460 or close to the upper limit that we like to give quinolones, we still wouldn't give the quinolone because it would be additive, and more than likely the QT interval will prolong if given alongside the amiodarone. Other drug-drug interactions, another one that comes to mind is daptomycin, which we use for gram-positive infections, and statins that we use for lipid-lowering reasons. And you can't use both of those together because that will increase the likelihood of myositis and rhabdomyolysis. So drug-drug interactions are really hugely important. Zyvox and psychiatric medications often don't mix for fear of inducing serotonin syndrome. So be aware that not only the creatinine clearance is important to know when dosing antibiotics, but in choosing antibiotics, drug-drug interactions become very important. The other major thing to know, obviously, when we're treating patients with certain infections, is that some antibiotics do not reach the tissue that we want to cure the infection. And just because in particular antibiotic says is active against an agent or against the bacteria, or it's listed as sensitive on the antibiogram, doesn't mean that it's going to work in vivo. So, for instance, a common example of this is nitrofurantoin and E. coli urinary tract infection that actually involves the kidney. So E. coli pyelonephritis, you could look at the antibiogram and see that the E. coli is sensitive to all antibiotics, including nitrofurantoin. However, if you use nitrofurantoin, you will not cure this person's pyelonephritis, most likely. And that's because nitrofurantoin, or macrodantin, which is the trade name, does not penetrate kidney tissue very well or prostate tissue very well. So really, nitrofurantoin can only be used for simple cystitis. It even doesn't penetrate the deep bladder tissue as well, so it really can't be used for serious cystitis as well, and especially emphysematous cystitis. Another example is daptomycin and the lung. Daptomycin, it has high activity in vitro against MSSA, MRSA, streptococci, and so forth. But unfortunately, again, if you use it in vivo, it will not take care of the respiratory tract infection and the lung infection. And that's because daptomycin, is neutralized by lung surfactant and is ineffective against pneumonias. And unfortunately, this is something that you don't necessarily learn or even would make sense. It's just simply something that you have to know. And that's why I ask, when you pick an antibiotic and tell me you want to give an antibiotic for a patient, I want you to read the monograph in up-to-date on the antibiotic so you can know what the antibiotic is used for and what the antibiotic cannot be used for. And this is generally stated and documented. So before using any antibiotic on a patient on your own or recommending, you really need to learn about it. You need to learn how it's excreted, like with the kidney issue, whether there's drug-drug interactions, whether the patient has allergies to it. I didn't mention about asking about pregnancy, but of course pregnancy is another consideration when choosing antibiotics. So